Hey all, Eric Christensen, pharmacist, back here with the Real Life Pharmacology podcast. Today I'm going to cover Clopidogrel. Brand name of that medication is Plavix. And this is classified as an antiplatelet agent. In practice, this medication is definitely used on a relatively frequent basis. One really important thing that comes to mind within the drug's mechanism of action. I'll talk a little bit more about this too as we get into drug interactions. But clopidogrel is what's called a prodrug. And that means that the drug is given and the active ingredient, the active component within that medication is not actually active right away. So what happens is the drug is absorbed and the drug is converted by the body into the active form that actually has the physiological antiplatelet type effects. So that's what a prodrug is, basically a drug that needs to be converted by the body into its active form. So I'll talk a little bit more about this in some of the warnings and adverse effects, as well as potentially touch on it on drug interactions as well. So when we think about classifications and antiplatelet agents, you've got to remember, what we're trying to do with these medications, and it's virtually always trying to prevent, platelets from aggregating together and ultimately prevent blood clots and things of that nature, where we stop the blood flow. And two of the most important situations are in the heart, where we can have a myocardial infarction, where basically blood flow is at least limited and potentially even totally blocked. We've also got the potential of blocking off that blood flow in the brain, which is a stroke. And clopidogrel can be used in both of those settings. I'm not going to go greatly into the nuances here, but clopidogrel is definitely more indicated for secondary prevention of ischemic stroke. Now, in patients who have atrial fibrillation and are at risk of stroke, thromboembolic stroke due to that, the agents that are going to be used are the anticoagulant type agents, like apixaban and things, medications within that class. So there is some nuance there, but from a big, broad, general picture, prevention of, future heart attack, prevention of stroke is where this medication is primarily used. Also, in numerous situations, it can be used as an alternative to aspirin. So if you got a patient that has not tolerated aspirin for some reason, you may see clopidogrel used as an alternative, again, to help prevent those blood clots from forming and issues surrounding that. Okay, so mechanistically, when that prodrug is converted, how does that medication work to inhibit platelets? So it inhibits P2Y12, which is actually part of ADP receptors, or kind of a subunit of ADP receptors. And those ADP receptors are on platelets. And this blocks the activation of GP2B/3A, which is necessary for platelets to start to come together, adhere together, aggregate together, and slow and stop that blood flow. So that's mechanistically how this drug works to inhibit the function of platelets. One thing that commonly comes up, patients who are undergoing surgery and things of that nature, and whether we hold this medication or continue this medication really depends upon the surgery and what's going to be done. But an important thing to remember physiologically is the lifespan of a platelet. Lifespan of a platelet's in the ballpark of 7 to 10 days. And mechanistically, this drug irreversibly inhibits the function of platelets. So that means that the body needs to replace the platelets to be able to regain that function. So skipping a drug, skipping a dose of clopidogrel may not, automatically prevent you from having bleed risk, because those platelets are inhibited for 7 to 10 days until the body has reproduced more and new platelets. So just an important point to think about. And, it's why we sometimes hold these drugs several days before surgery, is because of that lifespan of the platelet. But again, depends upon the surgery and depends upon what we're doing, whether or not these drugs are held. Adverse effect profile. I can't say I've seen a ton of adverse effects out in clinical practice other than the risk for bleed. These drugs inhibit platelets just like aspirin, and bleeding risk is a major concern with these medications. And you got to think about other medications that a patient may be on too that may increase bleed risk, which I'll talk about kind of in drug interactions too. Now there is one warning that I definitely wanted to talk about, and that is with the enzyme CYP2C9. So that is the enzyme in the body that actually converts clopidogrel into its active form. And if that enzyme is inhibited, or if a patient genetically doesn't have a well-functioning enzyme, that can potentially mean clopidogrel will not be as effective, and it may put a patient at higher risk for an event happening, like a heart attack, for example. So very, very important to remember that if you've got a patient that has genetic variations and they're a 2C19 poor metabolizer, that could potentially put them at significantly higher risk for an event happening. So important to remember that, definitely. And I'm going to talk about this a little bit more after the break when I talk about drug interactions as well. If you enjoy and want to support the podcast, definitely do that at meded101.com/store, meded101.com/store. We've got great resources for all practicing healthcare providers, various books with clinical pearls and case studies. Also, you can find pharmacists board certification study material. So we've got NAPLEX, BCPS, ambulatory care, geriatrics, newly released MTM certification as well to help you prepare for that exam. So definitely go check out those resources, meded101.com/store. With drug interactions, I'm going to first talk about the obvious. So if you've got medications that are going to increase the risk of bleed, you've got to remember to be, hyper diligent in that patient population to look out for bleed risk. So, obviously I think of aspirin, and aspirin can be used certainly in combination with clopidogrel, after a heart attack, for example. But we've got to be aware that we need to watch these patients closely. NSAIDs, ibuprofen and naproxen, a lot of those common NSAIDs absolutely can inhibit the function of platelets and may kind of have a compound effect of increasing the risk of bleed there. Anticoagulants like apixaban, rivaroxaban, warfarin, any blood thinning type medication, thrombolytics like TPA, those can all increase the risk of bleed and kind of compound that effect of clopidogrel. Now, we'll get into a little bit more controversial area. So omeprazole, esomeprazole, these medications can inhibit CYP2C19. And by inhibiting that enzyme, you do run the potential risk of reducing the effectiveness of clopidogrel. Now, it's still, to this day, as I'm doing this podcast, it is still, at least in my mind, somewhat controversial. We've had some evidence that says, yes, this is going to impact outcomes and increase the risk of, let's say, a heart attack. And we've had some evidence that says, no, there was no issues. So very, very controversial still. A drug like pantoprazole, if a PPI is necessary, is a consideration. In the event, that a patient is, just using the medication, let's say omeprazole, they're just using it for heartburn. Maybe we can step down and titrate down off of that medication. So that's a consideration to try to avoid this potential interaction. But again, still controversial to this day, at least as I'm doing this podcast. So that is a challenge. Hopefully there'll be more clear evidence as to exactly what to do. But those are some of the potential options that I laid out there. Fluconazole is another medication that can inhibit CYP2C19, and there is some potential evidence that it can cause some reduced effectiveness. So again, keep an eye out for that. Morphine is kind of a unique one that may reduce the effectiveness of clopidogrel. Again, maybe a little bit controversial as to how much clinically that matters. So I suspect there'll be more and more research over time on that, but I think it is something to be aware of at least, and consider what your options are, if there are other options, depending upon exactly what we're using that drug for. So those are just a few interactions I wanted to throw out there. Make sure you were aware of with clopidogrel. As always, there's usually a laundry list of medications, oftentimes with medications that are less used or less common, but always certainly a good idea if you're doing a clinical review, just to run a drug interactions check between a patient's medications and see what comes up and see if there's anything that we need to be aggressively changing or concerned about there. Go check out reallifepharmacology.com and get that free 31-page PDF, great resource of the top 200 drugs for pharmacy students, nursing students, nurse practitioner students, med students, and so on, where I really highlight important things kind of with each drug in the top 200 there. So go check that out. If you enjoy the show, would love a rating review. That's greatly appreciated. To the well over 100 people that have already done that, I'm incredibly appreciative of that. Certainly it helps grow the audience, grow the podcast, and get my message of medication education out there. You can track me down at reallifepharmacology.com. Hit the contact button. That email will go directly to me. Also, track me down on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. I'm going to leave it at that for today. Thanks so much for listening. Take care. Have a great rest of your day.